One of the biggest problems affecting aesthetic practices and this country, arguably, is cyber attacks. And when we think of cyber attacks, we've got them in the military, we've got them in the power systems, we've got them in the healthcare systems, but of physicians, the number one group of physicians being attacked are aesthetic plastic surgeons. There are a handful of bankruptcies that have happened for aesthetic plastic surgeons, the members of our society. There are a number of multi-million-dollar awards and a number of lawsuits from patients because their information's been divulged and so forth, and it's shut down practices for months. Recently, the Aesthetic Society, and that's the meeting we're going to starting tomorrow, made a partnership with Critica, which is a company, such that our physician members can avail themselves to a much reduced price of Critica. And the reason I bring it up is there's this campaign here, a Zoom call, excuse me, and I just wanted to draw your attention to it, especially for the clinicians here, but even corporate America, because an article recently in the Wall Street Journal, if I ask you what's the dwell time, which is the time between the attack and the actual shutdown, what's the average dwell time? I'm not going to put you on the spot. Most people pick minutes, seconds, or days. Well, the average dwell time right now in this country is 121 days. So they're creeping around in your system for months before they attack you. And during that time, they acquire all your bank accounts, all your photos, and everything, and then they attack you. And that dwell time, even though you think you're protected with your CrowdStrikes and all the rest, you're not, because those zero-day malware viruses are unrecognized. They've never attacked anyone before. So they're zero-day malware. And the only technology available right now and being used actually by the U.S. government, Department of Defense and Homeland Security and so forth, is Critica. So when we cut this deal with Critica, they can pick it up. The longest it's ever taken them for a zero-day malware is 2 minutes. And that's why they're on the Coast Guard and all these different ships and all that stuff. So the cool thing is, for the plastic surgeons here in the audience, this is a deal that was cut with the Aesthetic Society. It's been announced recently. Leadership, Tracy, our president, and others, and the board, and this recently was announced. So I would encourage you, if you have any interest in this subject matter at all, I would encourage you to go to that. Okay, now, you guys, I just want to remind you, can I have that mic? I just want to walk around. So this last session, before we go to the cocktail reception, is going to be surgery. I know when I've talked to each of you, as soon as we start moving to whatever subject it is, we launch off into non-surgical options. I want you to try to stick with surgery, because all day long we've heard non-surgery, and you're all surgeons. These are some of the best surgeons in the world up here. And I'm going to start at the top and work down. We don't have enough for everything, but I'm going to start at the face, probably go to the breast, and if we can, get to the body. And I'm not going to call on everyone on everything, okay? And I know generally what you like to do, but in general, feel free to add whatever comments you want. I'm going to start with, without a doubt, the most famous plastic surgeon in the world, Foad Nahai, the only one of two people who was in the president of the International Society and the American Society of Aesthetic Plastic Surgery, and the editor of the journal for how many years? 25, 30 years?
Only 50.
Yeah, right. So in any event, Foad, you have done countless numbers of operations, and people come from all over the world to see you for facelifts. There's so much going on right now in the world facelifts. We're going to get to it, don't worry. From, the deep plane and all this stuff, and I promise you we're going to get to it. You have such perspective, and you were there when Sam Hammer was already starting to go under the platysma and do extensive undermining and release the suspensory ligaments and so forth. And yet now you can't go a day without hearing about $200,000 facelifts, $300,000 facelift. The other day was one $500,000 facelift, and they were all this deep plane stuff. Then recently an article that was published, and you saw it, you probably are the one that edited it, deep plane versus mastectomies or SMAS facelifts, and whether or not there really was a difference long term. Years ago we did the twin studies, and we were looking at SMAS versus non-SMAS. You remember when we had the twin studies? Well, I think we need new twin studies again, and I think we need to look at deep plane versus lateral mastectomy or whatever you want. But we don't have that right now. And the public is being absolutely slaughtered with information on social media. Would you comment, based on all your years of experience, where you weigh in on this? I know where Dan does. We're going to get to that. But I'd love to have you weigh in on it, and maybe even a little bit about cost. But let's talk about risks. And the question I would ask, is the deep plane facelift the next BBL as it relates to risk?
Well, to quickly answer your question, it's already been proven that the deep plane in experienced hands is safe. But if you were to ask me if deep plane in the neck is the next BBL, with people bleeding and airway obstruction, etc., I would probably say yes, that's my major concern. Years and years ago, when the only marketing and advertising were the yellow pages and newspaper ads, we wrote an editorial on commercialization and commoditization of aesthetic surgery. Today, with social media, it's just out of control. Deep plane was a term coined by Hamra in 1992, and basically what he was doing was lifting the SMAS and extensively dissecting underneath. Today, deep plane has become a social media buzzword. It's become a marketing tool. And yes, the study that you referred to recently with Jim Stuzin as the senior author, absolutely no difference what you do to the SMAS. I've always advocated there's no facelift for all seasons, but all facelifts have 5 steps. They all need an incision, undermining the skin, managing the deep tissues, which is the SMAS. And there is ample evidence that you don't need to go deep to the SMAS to get a good result. The 2 leading European plastic surgeons, Johnny Botti in Garda Lake and Mario Pello in Rome, both internationally recognized. One only does plication of the SMAS, the other one only does deep work under the SMAS, and they both lecture internationally and show fabulous results. So it's a buzzword. It's a I don't want to use the word gimmick, I'll offend too many people, but it's a marketing tool. And yes, I've told my staff, if they call and ask, do I do deep plane, tell them yes. And then I tell the patient, based on my examination of you right now, and based on what I find under your skin, I'll do the right thing to give you the best and safest result.
Yeah, so first off, I would say all the surgeries have 3 steps: open, do the thing, and close. I don't think that the technique matters. I think if the results are good, and the patients see your results, and they resonate with your philosophy and the care, then the surgery is good, and patients will seek them out, and the surgeon will be busy. I think that it has been overutilized as a marketing term. Patients are confused because people are saying they do deep plane surgery when they do not, or they're confusing them with what that even means. Just by using the name, it means I'm a good surgeon. That's not the case. I've seen a lot of people who do deep plane surgery with not great results and not good outcomes from that. So it is confusing to the general public, but it's not synonymous with good or bad. So I think surgeons are getting caught up in how they market themselves direct to consumer via social media and other platforms, and trying to take advantage of the wave of interest to do more surgery. However, I do think that there are good and bad surgeries. And I think there are surgeons who do fantastic SMAS facelifts and those who do fantastic deep plane work. And that the problem is we're lumping them all into the same category, like you said, commoditizing the surgery and focusing on the buzzwords instead of the surgeon. Just saying like, hey, the brand is actually the surgeon. It's not the surgical maneuver.
Well, some of us have been around long enough to remember this, but when a group of surgeons who touted their procedures were all on a panel, smastectomy, deep plane, SMAS, high SMAS, low SMAS, were showing their results, and everybody shows their best results, and each procedure looked fabulous. So I decided the most important thing I needed to do was look at their wives and then track their wives over the next 5 to 6 years. And as it turned out, every single person who was doing that procedure on their wife, all the results were the same. Over time, there was laxity and loss of volume, in the bone and the soft tissue and skin changes. So bottom line is, having a 35, 40-year perspective on this since the 80s, I agree with everything that's been stated.
Yeah, and I think we're not only doing this with facial surgery, we're also doing it with breast surgery. Lots of people are not being intellectually honest about what they're doing, and it's like tissue preservation, preservation 1.0, preservation 2.0, under the muscle, over the muscle, dual plane is bad. And it's the same thing. Sometimes dual plane is the right operation for that patient. Sometimes preserve is going to be a great option. Sometimes over the muscle is going to be the best option. And so I think there's just so much marketing going on, and we're not holding each other accountable to the BS that is on social media.
We're going to come back to President Bay. Hold that thought after Kiya gets a chance.
Sure.
Our immediate past president.
Thank you. I think a lot of the comments have already been made, and I believe I agree with everything. I always quote Foad on there is no one facelift for all seasons. It's very true. When somebody tells me I'm doing a deep plane, I say, so what do you do? Doesn't mean anything. If you listen to a lot of these folks who are getting at the podium and say, I'm doing a deep plane facelift, all the techniques are different. Where they make the skin incisions, where they make the incision into the SMAS, what they're doing to the SMAS, how much undermining they do. They're all doing different techniques. So, I spend sometimes half an hour with my patients, explain to them exactly what I'm doing, and at the end of half an hour say, so doctor, is that a deep plane? I'm like, yeah, it's a deep plane, but whatever it is. So you have to ask yourself, are you adding volume? Are you subtracting volume? If I have an Ozempic patient with loss of volume and loss of atrophy of the tissue, SMAS layer, I'm not going to do a deep plane. There's not much of a SMAS to go under. So that patient, you want to add volume. So you have to decide what are you doing for that patient to customize the outcome to get the best results. If the result looks good, it doesn't matter what you term it, patient will be happy. If the result is bad, patient will not be happy if you did a deep plane.
You can always take a picture and show it to them too, and I post that stuff and show them the dissection, so you can actually say, hey, that's where I was, there's the zygomatic muscle, there's the masseteric, area, and I actually do that in my cases because I always worry about them saying that. And as a side note, I'm actually in the deep neck a lot, so I know it's controversial, but I take glands on 95% of patients, and I just did a study that showed that even thin patients have more of a problem than others. So I do think that you shouldn't be there if you don't understand the anatomy, but it's just as dangerous to be in the face as it is to be in the neck in some regards, at least with regards to permanent nerve injury.
Just one other comment about
Sure.
the twin study. We had to also stratify whether they were on GLPs or not, and whether they...
That's right. We didn't have to deal with that back then. Oh, go ahead, Fawn.
I'd like to comment on your comment that it's really about the surgeon and the surgery. What I've learned over the years, and I look back over my career and training, what I learned was good surgeons get good results regardless of technique. I saw that in my training as a plastic surgeon. I saw it in my training as a general surgeon, and I see it today when I come to meetings and see my colleagues present. And what makes a good surgeon is they make the clinical judgment, they plan the procedure, they've had experience, they have nothing to prove to themselves or to their colleagues, and then the willingness to change course during the procedure. And this is what I tell my patients. When I'm under your skin and I've looked at your deep tissues, how mobile they are, how thick they are, that's when I decide how deep we go or whether we just do application. So it's really a question of willingness to change based on what you find.
And an article that Dr. Stevens is a senior author on when I was really just a fellow, we showed 5 or 6 different facelift techniques, including the very first publication of preservation-style deep plane approaches, and explored the differences in outcomes, but also time in the operating room, potential risk of complications, and aesthetic results. So that was really a potpourri of different approaches, different surgeons, but also Dr. Stevens and others working on changing their techniques from patient to patient.
Consumer alert, consumer alert. Deep plane is the buzzword today. Tomorrow the buzzword is going to be conservation. Credit goes to
maybe endoscopic.
Facial plastic surgeon in Connecticut, Neil Gordon, who in 1999 actually published on limited delamination of the face, limited separation of skin from the deep tissues. He's been doing this for over, almost 30 years, yet now it's been rediscovered, labeled as preservation. So consumer alert, the next buzzword is preservation. We already have preservation rhinoplasty
and breast.
Preservation facelift is coming.
Soon tummy tuck.
Okay.
What's next?
Before we
Preservation breast dog.
Before we go to breast, hold on, because you just reminded me of something. I'd like any of you who have any comments about this. The other buzzword lately is endoscopic facelift, and there's no consensus. You know, Renato has his approach. Other people have theirs. Some have just limited incisions in the temple and then do a regular neck. Any comments on endoscopic, limited incision type?
I mean, again,
facelift?
they're calling it a scarless operation. That's another buzzword. Now we're not to scarless. I mean, I don't know of any surgery.
We know there's a scar.
Yeah. Right. So exactly. So I think that's another buzzword. Again, I mean, that's what Foad said. Good surgeons get good results. So I don't know if you can get a good result with endoscopic, so be it. But a lot of times and also there is an aesthetic judgment, what looks good in your eyes. I have corrected a lot of patients coming in with these spark-looking eyebrows. If that's your aesthetic, and fox, they call it fox eyes now. I mean, if we were not born as a fox, why are we creating foxes? So to me, it's your aesthetic judgment, what looks good. There are patients that I see from SoCal that doesn't apply to Northwest, where I work. And so it depends on your aesthetic judgment, your patient population, what they want, and what you can deliver safely.
Yeah, it's a mistake to think that it's aesthetic, because I feel like we are not artists, we are anatomists, and great anatomy never goes out of style. So when you do an endoscopic temple lift or brow lift, if you put it back where it was, you're not at risk for defaming that person's character or face. So I think that that's the big piece that we're seeing, that movement back, which there are a couple articles in the last 6 months that have all focused on that reemergence of like a more natural looking result. But you all said the same thing, that endoscopic is pitched as scarless. Anytime we change our language to address the fears of the population, that's marketing. When we're talking about anatomy and how it guides our outcomes, that's real science, and there's a huge difference between the two.
Endoscopic facelifts are nothing new. 1992, Nick Issei, Louis Vasconez, and a year later, our group at Emory, we even wrote a book on endoscopic plastic surgery. It worked well in patients who were young, who had elastic skin and needed very little work. As I grew up as a surgeon, as the hair started turning gray and then white, so did the age of the patients that I saw. So that in 1993, 95, with Monty Eves and others, yes, the patients that came were closer in our age, and we could do it endoscopically. We could eliminate scars. Today, they're my age, or older than me. There's no way you can do it endoscopically. But again, everything goes in cycles. Endoscopy has been rediscovered. Deep work in the neck has been rediscovered. So has lip lift. I remember 48 years ago, Louis Vasconez showing me how to do a lip lift. And all of a sudden, we've rediscovered it now.
Complex problems for very simple, complex solutions for simple problems. It's like we're chasing something here. You know, you're trying to adjust brow position by a millimeter, and then you look back and you say, and those patients can be very unhappy, because if they're very young and they have very few problems, and you're intervening and making a very subtle difference that only the few of us up here can even see, then it's not as powerful.
The other thing is, we were in a panel, I think it was with Foad at ABAM, and we had two speakers who gave presentation on endoscopic facelift. I won't mention names. And Foad knew the answer, but asked the questions so they could answer it publicly. How long does this operation take? 14, 15 hours.
Unsafe.
So scarless, but swollen forever.
And I've seen two frontal branch, unilateral frontal branch nerve, not neuropraxias, but complete loss of the frontal branch from scarless facelifts in my area.
So everyone knows what she's talking about. That's a permanent nerve injury. You can't raise your eyebrow. Okay, let's move a little south, and I'm going to go to you, Ashley.
All right.
Let's start with Preservé. Why don't you talk to us a little bit about it, what your thoughts are, and then we're going to get some opinions of some panelists. And if you have any conflicts as it relates to Motiva, please disclose them.
I am a stockholder. I think Preservé is great for a select subset of patients. I think it opens up a whole new market. I don't think it's for everyone. And I think as everybody's moving towards, they talked about it all day today, people want more non-invasive, faster recovery, low downtime. I think Preservé really is a procedure and not really a surgery. It's kind of how you can explain it to patients. They're awake. We do it under IV propofol. There literally is no downtime. They can drive their kids to school the next day. So I think it's great in that way. I think a lot of people are trying to apply it to every single person, massive weight loss people, revisions, and I think that we're going to see a lot of issues with, waterfall deformity, malposition, et cetera. But I do think it is very positive.
Okay.
No, so Preservé is, sorry for people who don't know, you basically introduce this channel separator, create a tunnel, then you introduce this balloon that you expand the circummammary ligament, and then deploy the implant through a funnel.
Okay, so there's no sharp dissection. It's not traditional surgery. It's a balloon. You pump up the balloon and it pops the tissues apart. There's a limit to how much size you can put in. I'm not sure the largest you've used, or the panelists here. You don't have control over the pocket. You have limited control compared to if you have a headlight and you're doing surgery. And you can only raise the breast only so much. But it is local anesthesia.
Yeah, I think the pocket is pretty tight. I was having this debate with somebody who compared it to the tuba, which is, transumbilical breast augmentation. I think this is a completely different thing. The balloon was designed in a way that it's not the same as an air sizer. Some people are using urethral sounds and air sizers. When Manuel and the guys at Establishment developed the balloon, it is really to expand that ligament more anteriorly than, medial lateral, so that you're really going to be able to place that volume exactly where you want it. And for a lot of people that, women that have maybe breastfed 1 or 2 children, they come into my office all the time. They're like, I don't want to be bigger. I just don't want to have this skateboard ramp concavity. And so you can place that implant exactly where you want it without really making them bigger.
Okay.
Because it's more of a top-down approach in
What
the
if they
planning.
have ptosis? Let's say the post-pregnant breast with
No, they need a mastopexy. And you can do Preservé with a mastopexy, but I think that sort of a little bit defeats the purpose, because you're going to have to do that under general anesthesia. And so the unique value proposition of Preservé is fast recovery for these moms and people that just want to get back to life. That's why it costs more, is because they're getting back that time.
So it costs more to the consumer to have a Preservé breast aug?
Yeah, some people are charging $50,000.
50?
50. Takes 45 minutes. The longest part is the 10 minutes of the tumescent, where, we're twiddling our thumbs.
The longest part was the training that you went through in residency and the years of experience that you brought to the table. So I wouldn't argue on pricing, because I think, pricing is what you want it to be. But I do think that the technique is unique and different. I was doing preservation style approaches in 2020, and that's why I came down and also participated. I also own some stock in that company. But I would just say that it opens the market. So you said the most important thing at the beginning was it opens the market up. In my practice, it's exclusively women that are maybe in their 30s to 40s. They want to have a quote-unquote ballerina breast. They want a smaller breast augmentation. They want it to match their body, feel more natural. They want it above the muscle so that it moves like a natural breast. They don't want animation, deformity, those other issues. They want to go right back to Pilates. So it changes the dynamic of the consumer in your practice. It fits my practice better than traditional aug did. But of course, there's 15 ways to do a breast augmentation. Dr. Stevens got the most experience with regards to breast surgery than anyone in this universe. And I'm sure when I trained with him as a fellow, I saw 15 different ways to do a breast augmentation. And it was always customized for the patient.
I don't have any experience with this current preservation breast surgery. I've not seen any of the results, but I recall before we started using the endoscope for submuscular breast augmentation, Black & Black, which was then known as Snowden Pincer, had this balloon device that you'd put in through the axilla, blow it up, no dissection, no bleeding, take it out, put in the implant. Then when we discovered the endoscope, we'd put the balloon in, take it out, look with the endoscope, and then dissect a proper pocket. So I don't know the research that was done, whether you or anyone else, once you've established that pocket, have gone in to look and see the extent of the dissection.
Yes, and I was using that exact Snowden pincer dissect like in 2020 before we had the new devices from Motiva. But yeah, I use an endoscope every time, go back in and look and try to visualize the ligament, but also bleeding and other things. I think you should be visualizing it still.
We use ultrasound as well for the tumescent and to make sure that we're in the right plane.
Okay.
And then the question I would have is warranty, on product going through a device like that.
So they're warranting the implants. I mean, I think there were some ruptures like early on because sometimes you can feel these bands in the tunnel. So I think that's why it's a good idea to have a lighter retractor and endoscope just so you can kind of divide those if you need to so that the implant will go in easily. That Motiva ergonomic implant is very like elastic.
Yeah.
And so I know Johnny's done some with the rounds. He's stronger than me, but that round implant is less elastic, and so I think it's harder to push it through that tunnel to get it into that nest.
One important piece of information for you non-surgeons, the reason why now we're going back above the muscle is because the new device from Motiva is different than other devices on the market with an outer shell that may be anti-inflammatory and reduce the risk of capsular contracture. So that's really the main reason why we're now pushing back above the muscle, because maybe it means we're going to have less of the complications associated in the past with
Actually, I disagree with that. I think it's not the implant because we just published a paper 4 months ago in ASJ, which is the only paper of its kind comparing submuscular to subfascial augmentation. And this was predated the Motiva implants. And that paper with the equal number of patients in both arms, one surgeon, which was me in this case, we followed the patients for 3 years, and we saw the cap-con rate in the subfascial augmentation was less with the predated Motiva implant. So I don't think it's the implant that's helping us, but I think the Preservé is Motiva is very smart in marketing, and I own the stocks in it, and I recommend you buy it. I own this stock, but they're very good with marketing. And they came up with the concept of preservation. And preservation is about preserving muscle. I've always been an advocate of why are we cutting the muscle to go under the muscle to do a cosmetic operation. And because in the orthopedic literature, there's now data that shows when you cut the muscle to go under the muscle, you're going to weaken the pectoralis muscle, which is one of your biggest 2 core muscles of your upper body, along with latissimus. So you're cutting the muscle, you're going under. Also, the preservation is the concept of preserving the circummammary ligament. In that Reinke paper that was published, and they're coming up with a new version soon, they showed that the circummammary ligament, that ligament that goes around the breast, like sort of infrastructure of the breast, is weakest laterally. So if you put a big implant, wide implant, that over dissect that, you're going to get more malposition again, which is something we showed in our paper. So the point of the Preservé and preservation the concept is preserving patients' infrastructure as we can. And now there's a market for those patients that you can use this device, but the device itself costs $2,000 to just buy it, and then you throw it away. So,
but also the Motiva implant is supposed to be placed above the fascia of the pectoral muscle. So it's not a subfascial implant.
Right, we don't have data on that yet.
Right.
That's the thing, there's no data.
And I wrote an article where we did a systematic review and meta-analysis of every implant placed above the muscle, including subfascial. So back in 2022 in ASJ, we had a good article where we looked at all that data, and it was confounding because some of the studies that were included as subfascial, like Ruth Graf, they had access to Motiva, and we had a mixed bag in terms of the implants that we saw. But I would agree with you that even despite that, when we controlled for those biases, we did find subfascial has a lower rate of capsular contracture. I agree with you on that. But I'm saying despite those risks, the new implant has a lower risk of CapCon, and that's why I feel more comfortable putting it above the muscle and above the fascia.
But one more thing, when you look at this, so that, you have to also be careful with when you analyze the data published by the companies. The data, they manipulate the data to get the data that they want, but based on what FDA wants. So when I published our paper, our CapCon rate was like 2.2, 2.3%, something like that. And when you look at Motiva data, is very low. It's like point something.
0.43%.
0.4%. So I listened to the presenter, and I raised my hands and said, wow, your numbers are low. Are you including Cap 2? No. It's only Cap 3 and 4. They're not including Cap 2. So in our paper we published, we included Cap 2. So most of your CapCons are Cap 2. So when you look at the data by the companies, you just have to be careful with how you take that data in.
But
So
I think more proof, though, sorry to interrupt, if you look at the capsule with Motiva implants, I do agree that like our capsular contracture rate is really low because of Bill, 14-point plan, all of those things. We're just more aware. But the capsule that the Motiva implant basically forms around the implant is basically non-existent.
Yeah.
And now, all of a sudden, that's a bad thing. We've been fighting capsular contracture forever.
So clearly,
And now people are upset that
It's going to
Motiva-
bottom out. It's going to lateralize. I mean, and the implant, the surface, the science behind that surface is, Bob Langer's lab. I was a PhD in bioengineering, and we did projects with Bob Langer back in 2006. And I remember when this article came out, and now they're using this technology in a way that's really fundamentally different. It is very different surface technology than other implants. And I think that we've got to give credit where credit is due for making better products for our patients.
Oh, I use it 90% of my patients. I love the implants. I'm just trying to tell you,
Be
you have to be
skeptical.
careful how you analyze this data.
So years ago, in the 80s, we did everything on top of the muscle, pre-pectoral. You guys weren't even born, probably.
Not quite yet.
Late in the 80s, in the early 90s, we had the FDA get involved in patient care. And as you know, we were forced to go to saline implants. That is when the huge increase of submuscular came, and out of that came dual plane. And that lasted for years till we, some of us fought through that, wrote articles in the Wall Street Journal and got Kessler off the FDA, and we got the silicone gel breast implants back. But during that time, we were also doing studies, controlled studies on texturing versus smooth. And we can talk about that all day, but we're not going to. However, the capsular contraction rate went down with texturing. And subsequently, because of animation deformities and all the things you've talked about, a person that's in the audience, I think, Ruth, are you here? There she is. The person that actually introduced subfascial breast implants is right there. And I've done them with her in Brazil. She taught all of us how to do subfascial breast implants. Ruth, can you stand up for a moment? This is Ruth Graf. She
Nice
invented, I mean, pretty much. Foad, would you give me that one? That Ruth is responsible for.
2000.
She's right there. Thank you, Ruth. And thanks for flying here from Brazil today. So then subfascial, and clearly they're outperforming the submusculars, there's no question, regardless of the surfaces. And this is why I don't understand why Motiva insists on going subglandular. I do love their proprietary texturing. It's very novel. I still am a big believer in Siltex. I know that some of you are not. Doesn't matter. I know what my capsular contraction rate is. And I did all subfascial for the end of my career. Not all, almost all. But as Deanne said, we did tens of thousands of them. And we've
think
got long-term
Motiva's
follow-up. And
fine.
that's the other problem with capsular contraction data. Number one, is it a 2, 3, or 4? Or so if that's one problem. The other problem is duration. Because you look at 1 year, 3 year, 5 year, 10 year, it's unbelievable. So when a certain company that starts with an M publishes their 3-year follow-up but doesn't give their 5-year follow-up, you know what they're hiding.
They presented the 5-year data at the meeting last year.
But initially they didn't. They were forced to do that. They were forced to do that by people like me.
But the numbers didn't change.
Well, they did with time.
Unless they're manipulating the data.
No, it's not manipulation.
Yeah.
It's just what they reported. And I asked them,
Oh,
why
wait,
are you
you're
reporting?
thinking I'm talking about Motiva. I'm not.
yeah.
No, I'm not. I'm talking about another one that was
yeah.
purchased by a drug company. But I'm not going to talk about it. Okay, so let's move on past the breast. We could talk about this for a long. Oh my goodness.
Next year.
Okay. Well.
To be continued.
Cocktails.
Okay, you guys are out of here. What? Oh no. To be continued next year.